So now we're going to start the skeletal system, which is, you'll see, a little bit more than just bones. Yes, you're going to have to know the skeleton itself, but we will go through some of the physiology and the important things about what the bones provide for our body. So, easiest thing obviously is that the skeleton is made of bones, and where the bones connect are called joints, and we're going to be going through those in detail and what they're made of and why they're where they are in terms of their function. And then the cartilages, there's 3 types of cartilage, we'll go through those, and then ligaments, as you guys know, connect bones to bones. So the skeletal itself, in terms of the system, has what's called the axial skeleton and then the appendicular skeleton. So when you look at this, what's in the tan here, this is considered to be the axial skeleton, and in the green is the appendicular skeleton. And some of the skills that you're going to be learning as a paramedic are going to involve drilling into the actual skeleton or finding sites in between the ribs where you will be doing what's called a needle decompression to relieve the thoracic cavity of air. So we'll be going through that and where the landmarks are and exactly what you're going to be doing with that. In terms of what I want you to know for the skeleton itself are these bones. And so I'm just going to go through them real quick. So up front on the anterior portion of the skeleton, this is the frontal bone, and it's also behind that is going to be the frontal lobe of the brain. Then you have the maxilla, which encompasses the upper portion just below where the nose is and below where the eyes are located. You have the mandible, which is the actual movable part of the face, and that is where your jaw is located. Then we have the clavicles, which are in the anterior portion, and then those connect and articulate directly to the actual sternum, and this bone here is called the manubrium, and we'll be going through that in detail a little bit later. And then the body of the sternum is this mid portion here, and then below you have the xiphoid process. Then we have the ribs themselves, and then the ribs connect to the sternum through what are called the costal cartilages. Then the vertebral column, this is your entire vertebrae, and obviously it goes all the way up into the neck and then down through the sacrum. And then this portion here, this is your pelvis, and collectively each one of the bones that are actually 3 fused bones, these are called the os coxae. And then the sacrum obviously joins the os coxae in between to join the left and the right side. Then the coccyx, this is going to be your tailbone. And then you have the legs. And so this is your femur. Then anteriorly you have the patella. Then medially you're going to have the tibia. And then laterally is the fibula. And then you have the tarsal bones, which make up the ankle bones and parts of the foot. And then the metatarsals and then the phalanges. Then on the back side, you're going to have the parietal bones, and then you have the occipital bone. Posteriorly, you have more of the vertebrae, which are the cervical vertebrae. We'll get to those in detail later. And then the scapula, then the humerus, then you have the ulna, which is going to be medial, and then the radius, and then you have the carpal bones of the wrist, and then the metacarpals in the hand, and then the phalanges. And then we already talked about the femur, and then the tibia, the fibula, tarsals, and obviously the metatarsals, and then the phalanges. So those are the bones that you need to know for the actual skeleton, and you're going to be needing to label these actually when you go through and do the benching portion of the exam. So make sure that you look at this piece that I actually posted already on Canvas. All right, so the functions of our bones are to support the body, it's our infrastructure, but they also protect some of the organs of our body, primarily in the skull. They protect the brain, and then the rib cage obviously protects the heart and the lungs. And then muscles, the skeletal muscles, which are voluntary, these attach to many of our bones, and we'll go through those in detail when we get to the actual muscle chapter. Then we store minerals and fats in the bone. Fat is in the marrow cavity, and then calcium and phosphate are the actual 2 minerals that are stored within the bone itself. And then hematopoiesis is really important because this is where the bones are actually the structures where in the red bone marrow, the red blood cells, white blood cells, or platelets are actually going to mature and they're going to develop in there. So very important site for bone marrow and then blood cell development. Then cartilages, tendons, and ligaments. So the purpose of these, they're connective tissues, and obviously they help provide some of that framework. So cartilage comes in 3 flavors. They are hyaline, elastic, and fibrocartilage. And hyaline cartilage is what surrounds the joint articulations where the 2 bones are going to be come together in many of our movable joints. Elastic cartilage is in the epiglottis and in the outer ear. And then fibrocartilage is what makes up the discs between our vertebrae, the meniscus, and then the symphysis joints, which are in the pubic symphysis, and then those that are between the bones of the vertebrae, which are where the intervertebral discs are. Tendons, like I said, connect skeletal muscle to bones, and then ligaments connect bone to bone. Hyaline cartilage is the first one we'll discuss, and this is, like I said, on the surface of the bones that form the movable joints, which are called diarthroidal or synovial. And then hyaline cartilage, and all cartilage, is actually made from chondroblasts, which are the cartilage building cells. And here I just want to point out this root word here, chondro, means cartilage. So anytime you see chondro, they're referring to something in cartilage. And then the word blast is going to mean to build. So chondroblasts actually build the cartilage, and then they mature to become chondrocytes. So cyte is actually going to mean cell. Cartilage itself does not have blood vessels passing through it. So when you injure cartilage, it's going to take a while for it to heal. And then surrounding cartilage, surrounding hyaline cartilage and what we call elastic cartilage, is this stuff that's called perichondrium, which is a protective layer around the cartilage. And then synovial fluid is actually secreted from synovial membranes into the joint spaces that form the synovial joints. And it's very important because this actually helps reduce the bone friction between the cartilage, and it's very important in terms of maintaining the integrity of the cartilage. So what you're seeing here is what hyaline cartilage looks like. And this stuff here on the outer layer, this is all that fibrous perichondrium that protects it. And then hyaline cartilage itself is pretty translucent. And what you see here, these little white areas, these are called lacunae. And inside the little dots, what you're seeing are the chondrocytes, which are the mature cartilage sites. Over here on the right, this is a slice of the cartilage from the trachea. And what you're looking at, this right here, this is pseudostratified epithelium, and it's ciliated, which is this little brush border that you see. And then this is the open space where the trachea has, where the air actually passes through. So posterior to the epithelial tissue is the cartilage, the hyaline cartilage, that helps maintain the integrity of those rings. And then further back in this area here, this is the perichondrium. And then what you don't see on here is the actual smooth muscle that is in the posterior portion of the rings that help allow for the trachea to actually dilate or constrict a little bit, depending on what it is that you're doing in terms of your need for air. Then elastic cartilage, this is what the epiglottis and the outer ear look like. So what you'll see is that the lacunae are actually clustered much closer together. And then these darker areas, these little fibers, these are the elastic fibers that help provide some of that stretchiness to the elastic cartilage. So I want you guys to remember about this, is that elastic cartilage contains elastic fibers, and that it's located, makes up the entire epiglottis and then also the outer ear. Then you also see here the perichondrium that helps protect and surround it. And then what you're looking at here is a little bit of fat tissue, adipose tissue, that also protects a little bit of protection. Then what you're looking at here, this is fibrocartilage, so it looks a lot more fibrous, kind of feathery in structure. And this one does not have perichondrium, so it lacks that little extra protective layer around it. And this is what our intervertebral discs are made up of, and that outer portion that helps protect the inner portion, which is where what's called the nucleus pulposus, and it's kind of a gooey layer that actually helps provide some of the ability for our discs to compress and then also dilate, fill with water overnight. And then what you're looking at here with these little arrows, these are actually chondrocytes within the fibrocartilage. Then our tendons and ligaments, if you were in my class where you actually had to identify tissues themselves in microscopes, but you don't, you're lucky. This is what tendons and ligaments look like under the microscope. And to me, they always look like bacon. So easy way to remember this. And what you're looking at here, these are collagen fibers and elastic fibers. And then these dark dots are the actual fibroblasts, which are the cells that help provide the fibrous tissue for the actual tendons and ligaments. And so our tendons and ligaments are pretty flexible, and they insert directly into what's called the periosteum of our bone. And they are able to withstand quite a bit of tensile force, but as you know, they can tear. And depending on the severity of the tear or the stretch that happens in the cartilage or in the ligament or tendon, it's going to determine just how bad an injury is and the degree of sprain that has actually occurred within this tissue. Then in terms of what a sprain is, this is a stretch or a tear that takes place in tendons and ligaments. A strain is what occurs in skeletal muscle, also caused by stretching, and it can also cause tearing. So make sure that you know for the test the difference between a sprain and a strain. Then in terms of the severity of the injury of what occurs in a sprain or a strain, it's going to be based on the degree of how much got damaged. So grade 1s are going to be your least susceptible to, having a long-term injury. The grade 3s are going to be the one where you actually have complete disruption and where you actually have actual tearing and a lot more inflammation. Usually for these, you're going to actually require surgery for the injury to heal. Then the bone tissue types that we have two kinds. We have compact bone and spongy bone. And compact bone is the bone tissue that surrounds all spongy bone, and it's the outermost stuff that you see in all bone. All right, whether it's a long bone, a short bone, a regular bone, it doesn't matter. So all this stuff, this is a femur, and what you see here on the outside, this is all compact bone. Then within the compact bone and some of the proximal ends here, for example, in the long bone or like in our ribs and our skull bones and our pelvis, we have a lot of what's called spongy bone. So that's this stuff, and it's called spongy bone because it looks like a sponge. And what you see here, this pattern, is called trabeculae. And within that is where you have red bone marrow. Like I said earlier, this is where all bone cells originate. And then some of the bone cells are actually going to mature here. So in your proximal ends of your femur, this is where you're going to have some of that red bone marrow. When you look at compact bone and you actually zoom in, you'll see these things that actually look more like dartboards, and these guys are actually called osteons. So osteons are the functional unit of compact bone, and anytime you see the word osteo, it's always referring to something in the bone. When you zoom in on an actual osteon, what you see is this big dark dot in the middle, and this is called the central canal, and what it has passing through it are blood vessels and nerves. And this is one of the reasons why bone itself is actually very good at healing, because it has a very good vascular blood supply. Then coming off these central canals, you see these little lines. These are called canaliculi, and they're little canals that will actually transport to these cells that are called osteocytes, which are the mature bone cells within compact bone. We also have them within spongy bone, and they maintain the integrity of the bone itself. Then as these osteocytes are actually laid down around the central canal, they form rings, which are called lamellae. And then, like I said, the osteocytes are going to be the darker cells that you see within the bone itself. Then the trabeculae is what makes up the actual spongy bone. And if you zoom in on spongy bone on a microscope, you'll see what looks a lot like cartilage. But this is the actual structure of the trabeculae. And what you see here in these open spaces, this is the bone marrow that lays within. And so within the actual spongy bone, what you'll see is there are areas here that are denser than areas that are a little bit less dense. And the less dense area, what that means is that they don't withstand as much strain from the actual weight of the body. When a bone actually strengthens or you lay down additional bone tissue around it, it'll actually be more in the outer layers. And what that's for is to actually provide more integrity for the bone where it's going to be under more stress or more tension. So areas, for example, where muscles actually insert into bone, those are going to be areas where you have a lot more bone laid down because of the tension that it has to withstand from the muscle contraction that takes place. And then also in here, what you'll see, for example, this is the femur. This is where the femur itself, along the head region and the neck, has to withstand a lot more stress from the actual weight of the body. Then bones themselves are classified according to their shape. So we've just kind of looked at some of the long bones that are going to be longer than they are narrow. And then you have irregular bones, like your vertebrae, for example. You'll have flat bones, like your sternum and your ribs. And then we'll also have some short bones, for example, like those in your carpals and your meta and your tarsals in your ankles. So long bones, just definition, they are longer than they are wide. They're going to have enlarged ends, and they are very important in terms of maintaining the integrity of our ability to move. Flat bones are flat. They contain a lot of bone marrow there. And then shorter bones, and these things that are called sesamoid bones, for example, are bones that form within a tendon, and the patella is a perfect example of this. You'll also have some sesamoid bones in the feet where some tendons run along them, and then also a little bit sometimes within the hand. Then irregular bones, these are going to be just in a regular shape, so your vertebrae, your hip bones, these are examples of that. Then in terms of our long bones, two of the things that are very important that I want to make sure that you remember are what are called an epiphysis. This end here is called the proximal epiphysis, and then down here at the end is the distal epiphysis, and then in the middle is going to be the diaphysis, or what is known as the shaft. Within the epiphysis, what you'll see are these little lines here, and these lines indicate that they were the areas where the bone itself actually elongated. So you'll have proximal epiphyses, and then you'll also have distal epiphyses, and then within that you'll have that growth plate, and then once it fuses and fills with the bone tissue and hardens, then it becomes an epiphyseal line. The articular cartilage is what is going to surround the ends. So this is the end of where the femur actually inserts into the joint where the os coxae, where it forms the hip. And then down here on the distal end of the femur, this is where it would articulate with the tibia and then form the knee joint. So we'll be going through that in a little bit. And then the nutrient foramina, what you see here, these are the openings in the actual bone tissue that have blood vessels that pass through and then provide the blood supply for the inner portion of the bone, but then they'll also have embedded within the pieces that then flow into the central canals of the osteons. Then the endosteum is going to be that innermost layer of the marrow cavity. And within that, when you're a baby, you actually have a lot more red bone marrow within these marrow cavities. But then on the proximal ends here, for example, of the femur and then of the humerus, you have the spongy bone where you're also going to have more of that red bone marrow. But then the medullary cavity, this is where as you age, you're actually going to be having more of the fatty marrow, which means you don't have as much bone cell, as much blood cell activity in terms of its development. Then when you look at how the actual osteons lay down, you'll see that they're actual rings. And then here in this diagram, you can see where the actual vessels and the veins, the arteries and veins pass through and then provide that integrity for that long bone. Then bone markings, there are a number of different bone markings. What are called projections are things that grow out from the actual bone surface. And oftentimes what these projections are for muscles to actually attach and for ligaments to actually attach. So as we go through these, you'll see that they have a number of different names. So for example, a crest is going to be kind of a raised ridge. You'll have a foramen, which is going to be an opening. It can be large or it can be small. You can have what are called lines, which are places where you actually have muscles that will attach. You will have condyles, which are these regions here that usually form joint articulations. And then you'll have these little epicondyles, which are little areas where muscles will actually originate. And then in some cases, you will have what are called facets, which are places where bones will actually articulate with each other. So this is, for example, a thoracic vertebrae where the rib will actually articulate. And then you have this little facet here, which is other vertebrae will actually attach. And then you'll have processes, which are more pointy things that are, for example, here the spinous process in the vertebrae. And then a trochanter. Trochanters are actually also bumps that are places where muscles will insert or tendons will actually connect to. Then heads are going to be regions, for example, here this is the part of the rib head. This is the head of the femur. You'll have a head on the humerus. And so these are also going to be points where you have joint articulation taking place. All right, and then we'll have depressions, which are going to be kind of indentations. Sulcus and a fossa are a perfect example of this. And then we'll have openings where you'll have vessels that pass through there. You'll have nerves that pass through there. And they will look like little notches or openings. So you'll, for example, here in the skull, you'll have sinuses that have air and then membranes will surround this. You'll have a meatus, which is an opening. For example, here, this is the internal meatus, acoustic meatus, where sound waves actually pass through. You have an external acoustic meatus on the opposite side, on the lateral side of this temporal bone. There will be notches, there will be grooves where, nerves and vessels will insert into. And then, for example, here, this is a foramen where the facial nerve passes through, and you'll also have vessels that pass through there. Then on the anterior portion of the skeleton, you'll have what's a very, very important area, which is our sternum, obviously. And you know that below this is where the heart is located. This bone right here, the uppermost bone of the sternum, is called the manubrium. And then that has a seamless articulation here through this fused joint to the body of the sternum. And then below that is going to be the xiphoid process. And so what I want to point out here is you can have 7 true ribs, and why they're called true ribs is because the rib itself articulates directly to the actual body of the sternum or to the manubrium. So like this is your first rib, articulates directly to the actual sternum. And then you have the rest of the ribs, the true ribs, which also connect to the body. And then the false ribs connect to the sternum itself through the articulation of the actual 7th rib. And then below that, you have floating ribs, which don't have an anterior articulation, or what you call a distal articulation. The ribs themselves, their proximal attachment is actually to the actual thoracic vertebrae. Then the other thing that I want to point out here that is very important are the intercostal spaces. And so what this means is that they are the spaces in between the ribs. And so one of the things that you're going to be learning is how to insert a needle into the thoracic cavity through the actual intercostal muscle and relieve some of the air that can build up in there when somebody is having a pneumo, right? A pneumothorax means that now you have air building up within the thoracic cavity, and it's usually because of a lung that is actually leaking air. So what you're going to be doing is you're going to be inserting into these intercostal spaces a needle. So what you do is first you're going to palpate and do this on your body. You're going to feel for the sternal notch, and then you're going to run down the midline, and then you'll feel a little spot where it actually kind of drops off. And where that little drop-off point is, that is the articulation for that 2nd rib. And so you run your your finger along that portion, and then you're going to come along this midline. And so up here, on this spot right here, this is where the actual clavicle articulates. So if you look over here, here is where your clavicle is. And right at that mid-clavicular line, going straight down, so the clavicle would be right here, you go straight down into what's called the mid-clavicular line, between the 2nd and 3rd rib in the intercostal space. And this right here, this is where you actually go in and insert the needle to begin the needle decompression. You never insert it just lateral to the sternum, because right here, obviously this is the left side, this is where the heart is located. All right, so what you're trying to do is you're trying to relieve any air pressure that is actually building up inside here. So if you did that here, obviously you're going to do something that could get very close to that pericardial sac and actually injure that. So that is why we move laterally. We go to that midclavicular line, and then you either insert the needle here in the 2nd intercostal space. You can also go into the 3rd intercostal space, and then here is the 4th intercostal space. So when you see this on an actual human, and they've actually been nice and drew this in, this is your midclavicular line here. So you find the sternal notch, you move down, and then you're going to find that spot where it kind of just drops off. And then here is that 1st intercostal space where you have that 1st rib right below the clavicle. And then here is the 2nd intercostal space. The 3rd would be here, and then the 4th would be down here. And so what you're seeing here on the right is where you had actually put in a 10 gauge or a 14 gauge, whatever the biggest needle that you have. And what you're doing is you're actually going to just be puncturing through the skin and through the muscle. So you're not inserting the needle in all the way. If you did that, you would actually cause even more damage if you actually end up hitting some other tissue. So what we're trying to do here is we're trying to just relieve air pressure. And so when you learn to do this in the cadaver lab, it's just a little poke that is going to be passing through. So if you think of a rack of ribs, that is the density of the muscle that you're actually pushing through. So it's not very much. And then what you see here on the outer portion of the actual needle is a catheter. And so what you do is then you thread the catheter in through the hole that the needle did, and then it's the actual catheter that goes into the space, not the full needle. And then what will happen is, as you thread that in, you'll hear air leaking out, or you can actually attach to it you can have saline, like a little 3cc syringe, or if it's a 10cc syringe, and if you see bubbles coming up into the saline, then you know that you've got air leaking out. Then when it's time to insert another needle, because yes, there will be blood and it can actually clot in the little hole, then you insert another needle lateral to the space. And then you always go lateral when you're adding needles into this space. Oh, the other important thing to point out here, this neurovascular bundle. So the neurovascular bundle, what it is that when you look at the actual ribs, inferior on the ribs on the internal side, just underneath, that is where the neurovascular bundle is located. So it's got a thoracic artery, so intercostal artery, intercostal vein, and intercostal nerve. And so that is why you never, when you put in a needle, you never go from the bottom up, okay? You're always going to go from the top down. And so what is taking place is you insert your needle from the top down into that intercostal space, and then that's how you relieve the actual air. And so you can see here where they're actually doing the needle decompression, they're going in at an angle, right? So they're just going in perpendicular to what you're seeing here on the chest, and then inserting that needle going down at a slight angle. Then sometimes in place that I actually really like to do the needle decompressions is going to be in what is called the mid-axillary line. So what you're looking at here in terms of what you see here, the armpit itself is called the axilla, all right? And so what you do is you're going to find that intercostal space between the fourth intercostal space or the fifth intercostal space. And what you're looking at here, this is going to be between the third to the fourth rib or the fourth to the fifth rib. And so what's really important for this is that you're looking at where to relieve that. And usually it's going to be, you form this little triangle. And then what it is that it's a line that would be just inferior to where the nipple is, and then superior just to where you have that cleave, where you see where the pectoralis muscle would be passing through, and then that forms the armpit. So this is also the spot where you can very nicely insert to do the needle decompression. If you've ever had the opportunity to go into the trauma bay when you bring in a trauma patient and they have to do a decompression with a chest tube, this is one of the spots where they're going to be actually inserting that chest tube into. And it's an extremely painful procedure for a patient who may still be conscious, but what they're going to be doing is actually oftentimes relieving more of that air that actually built up in there, or in some cases where you're going to have actually blood that has filled into that space. But that has to be relieved because of what it's doing to the actual lung tissue, and then actually what can end up happening with the heart and it moving into the opposite side of the chest. Then the other skill that you're going to be learning is how to do an intraosseous IV access. So what you do is, we call it an IO, and what you're doing is you're actually drilling into the actual bone tissue. So what you're going to be doing, this right here, this is called the greater tubercle of the humerus, and then in between, this is the space that's called the intertubercular sulcus. Then over here, this is the lesser tubercle. So you've got the lesser tubercle, the greater tubercle, and then this is the humeral head. And the humeral head actually articulates with the scapula just below what's called the acromion process. And then this right here is the coracoid process. Up here is the clavicle. So if you run your finger along your clavicle and go to the end, all right, where it's going to be attaching to that sternal end of the clavicle that connects to that acromion process of the scapula, and you feel this little bump, you drop that below, and then just lateral to that, you'll have the deltoid muscle is here. And then if you turn your arm, so you keep your arm extended, fully extended, and then turn your thumb to your butt, so you're internally rotating the humerus, you'll have this piece, the greater tubercle, exposed. And then where you're going to drill in is going to be at a 45-degree angle into that greater tubercle. And why we're aiming for that is because this is a huge marrow cavity. And then directly connected to this is what you can see up here is you have the subclavian vein. And the subclavian vein will be actually running directly in to the actual brachiocephalic vein that then enters into the superior vena cava that then goes into the heart. And so this is why we like doing the IOs here to get the medication. Oftentimes, if you're trying to resuscitate a patient, this is a great spot to do the actual epinephrine. A lot of medics don't like drilling up here because obviously when you're resuscitating somebody, there's a lot more going on. You've got CPR, right? You've got ventilation taking place. But this is the fastest route for that medication to get to the heart. So this is why the IO into the greater tubercle of the humerus is such a great spot. Then when you look at the tibia, this is a preferred spot for drilling to do an actual IO on the tibia. The tibia is going to be the medial bone, the large shin bone that is on the lower portion of the leg. And then up here is where the humerus articulates with the condyles. Then just below that, so right here would be the patella, all right? You drop below that, and then you're going to find what's called the tibial tuberosity. And this little thing is what sticks out on the top of the shin, all right? So you find that spot, all right, your tibial tuberosity, and then you are going to drop down about 1 to 2 centimeters, so 1 finger to 2 fingers, depending on the size of the person. So if it's a child, you're dropping down 1. If it's an adult, most likely you're going to be dropping down 2, especially if they're taller. Then you're going to move medially into this space here, which is part just below where the condyle is located, And then this is the marrow cavity that you're wanting to insert into. In this one, you're actually going in at a 90-degree angle when you do the drilling, and then it's a full drill, right? There's no catheter here. So you drill into the actual bone, and then you remove that needle. So you're going to remove this piece of the actual portion of what you drilled in, and then this is the piece that stays in. And then going in through the needle, that is how you're able to get the medication in. So again, you find the tibial tuberosity. This is the key spot on the proximal end of the tibia. And then you go down 1 to 2 fingers, and then you go medial into that space where the marrow cavity is located just below. Then if you're going to do a distal tibia, what you're going to find is what's called the medial malleolus. And the medial malleolus is that bump on the inside of your ankle. The medial malleolus is just across from the lateral malleolus. So don't go to the lateral malleolus because this is the fibula. This doesn't have enough vascularization and enough marrow space for us to be able to drill in. So where you go in, again, 90-degree angle into this region that is just above the medial malleolus. So you find the medial malleolus, you go up 1 to 2 centimeters, and then you drill in, and then that is where you're going to put in your IV access. And again, these are only going to be areas where you access to go into the vascular bundles that are located within the actual bones if you are unable to get an IV. But even after you've done an IO, it is really, really important to get an IV line in because these IOs can only stay in for 24 hours. They're going to need to get one in the hospital anyway. And it is also possible for these to get dislodged and come out. So it's very important that you practice these, that you get good at these, and that you get good at actually securing them to the limb when you're actually doing the insertion. And so when you're doing the cadaver lab, you're going to get lots of reps at doing the drilling and putting in the IO, but you're not going to get a lot of reps in terms of attaching it. So where you can get a lot of these reps are going to be on the actual dummy bones that we have, where you can also learn how to do these. So make sure you guys, you get lots of reps at this. You're going to be doing a lot of these as a medic, especially when you're responding to codes for individuals that are very difficult to get IVs, and obviously IV drug users that have collapsed veins. Then we have the distal femur. The distal femur is an area that is obviously the least common in terms of putting in an IO. So what you're going to do is you're going to go to the femur. You locate here, it says where the patellar surface is and where the actual patella is located. And then you go posterior to that about 1 to 2 centimeters. So about a 2 centimeter on adult. And then you're going to go into the marrow cavity here on the distal end of the patella. And this is midline. So what you see here on this space, now you're actually going to right about here. So you find the patella. You go up about 2 centimeters, about 2 finger widths, maybe 1.5, and then boom, this is where you're going to do your drill again, perpendicular. So the only one that you're going in at a 45-degree angle is going to be the one up on the humerus. All right, so those are cool things for medics to know, and so you know where you're going to be doing these drills, and it's always fun to get the medic toys out. Then in terms of how bone grows and develops, so obviously it begins when during the embryonic stage, and then it's going to continue and it's going to develop throughout as the fetus grows. And in the long bones, what is going to happen is that you're going to have hyaline cartilage, where is what all bone originates from. And then you'll have areas that become what we call ossification sites. So they'll have primary and secondary ossification sites. And these are what are going to form the little growth plates that you see here. And this is where bone elongation is going to take place. So the process of ossification, so if you ever see ossi in a word, that is just telling you that you're referring to bone. All right, and so this bone is actually going to form within hyaline cartilage, or in some cases a fibrous membrane. So for example, our ribs or skull bones, they actually form within membranes themselves. The long bones are going to form within hyaline cartilage. Then in terms of the phases of ossification, one of the cells that I want to make sure that you know is called an osteoblast. An osteo, again, bone, blast means to build. And so these are the bone building cells that are going to help provide that integrity for the tissue. And you'll find osteoblasts within spongy bone and always within compact bone. And then the region here, again, in the distal ends of the long bone, so this is your proximal end, this is your distal end. These areas here are where the bone itself is going to grow and elongate. So during birth, you're going to have the bone that is obviously going to develop within the hyaline cartilage, and you'll have articular cartilage that's formed on the outside, and then you'll have the what's called the epiphyseal plate, which is also made up of hyaline cartilage. And then within, you'll have that endochondral growth. So let me just zoom in on this. So what you see here, this is the distal end, for example, of a long bone. And this region here, this is called the metaphysis. Metaphysis just means the area of transformation from one tissue to another. And so what takes place is that this innermost region here, this is where the bone hardens. This outermost region, which is this outer area here, this is all cartilage. So as you grow, all right, this right here is your growth plate. And so the area of the growth plate that is going to elongate and help you attain your height and respond to growth hormone and also to the sex hormones, estrogen in females, testosterone in males, to grow, this is where this is all going to take place. So what we have here, all of this is hyaline cartilage. And then slightly below that, what happens is it starts to grow. You get the zone of proliferation, and then that starts to line up, and then it grows. So these areas where you had the lacunae, it actually starts to hypertrophy and increase in size until these little areas start to crack open. And then you start forming these little channels, and this is where the actual channels where the calcium and the phosphate are going to be deposited. And then from here, this is where the bone is going to start hardening. So when you look at this, what is really cool is this area here, this is where the bone is now hardening, and then from the bone is actually going to grow from the inside out, and then that's how it's going to actually elongate. Then in adults, so obviously when you're an adult, if you've finished puberty, you've attained your maximum height, now you're not able to actually grow and get longer, right? You're not going to grow in height. So now what happens, and as an adult, you have what's called appositional growth. So we went from having endochondral growth or intramembranous growth as an embryo, a fetus, and then as a child, and then growing into puberty, and then we go into what's called appositional growth. So the type of growth that happens in an adult is called appositional growth. And what this does is that it actually thickens on the outer portions, and then you'll also have some thickening that takes place here within the inner regions of the actual trabeculae, where they get stronger depending on how much tension is expressed onto that bone. And so you'll have increased bone deposition along here, and then that is called the appositional growth. And this is obviously very, very important going into adulthood, and then as you gradually age and become an elderly person, because the more bone you have going into being a geriatric person, the denser it's going to be, the better off you're going to be, the less likely you're going to be to actually get fractures. And so this is why it is so important that throughout your life you continue to do resistance type activity that would involve, weight training obviously is awesome for this, but it's very, very important that you do that. All right, so then what we have here also, this is basically an x-ray of a child's hand and a wrist. And what you're looking at here, these open spaces, all these are the regions where the growth plate is located. And this is where the bone elongation is going to be. So within this is where that metaphysis is. And so here's the radius, here's the ulna, and you'll see that right here, obviously that is a spot where it would be actually elongating. So it's very important that if a child has an actual injury to a long bone and it's on the distal or proximal ends of those long bones, that they go to a pediatric orthodoc, because you want to make sure that these bones get lined up properly so that the bones themselves and the growth plate doesn't get affected when that child is actually going to be growing, because you don't want damage to occur and for those plates to actually seal prematurely. Then the cells that the bone comes from are osteogenic cells. And osteogenic means bone, and then genesis is going to mean it's going to grow and become something. So the osteoblast, remember, these are the bone builders. And then the osteoclasts, these are cells that we're going to talk about a lot more when we get into the actual, talking about the endocrine system. And osteoclasts are very important in bone remodeling, but they're also important in helping maintain our calcium homeostasis, because calcium is a very, very important ion that we need for neuron signaling and also muscle contraction, and then obviously within our heart. So we'll be talking a lot more of the role that the osteoclast actually has, and then also the osteoblast. And then the osteocyte, these are obviously going to be your mature bone cells that are also important in terms of sensing strain and then providing signaling to the nervous system to let it know, hey, when we have actual tension placed on a bone itself. Then the things that are going to determine calcium levels in our blood, and here I'm going to introduce some of the actual hormones that we work with, that our body has and secretes to deal with any kind of calcium and phosphate homeostasis issues. So the word hypo means below, calci means calcium, and then the word emia, the ending, means blood. So hypocalcemia means that you have low blood calcium in your blood. And why this matters is that we need calcium to have signaling happen within neurons, and then also again for the muscle contraction. So it's very, very important for that. So if your blood is low in calcium, what is going to happen is you're going to have a hormone that's called PTH, and PTH stands for parathyroid hormone. And it's a gland that is located just posterior to your thyroid gland. It's a separate gland from the thyroid. And what it does is that it secretes PTH, which is the hormone that then is going to target the osteoclasts, which are the cells that actually help dissolve bone. And when that happens, it dissolves the hardening of the bone, and then that calcium and phosphate will then go into the blood, and then that will raise the calcium levels in your blood. What it also does, PTH also targets what's called the distal convoluted tubule in your kidney, and what it does there is it actually targets little channels in those tubules to reabsorb calcium from the filtrate, which would become urine, and then bring the calcium that's in there back into the capillaries and into the blood. So that helps raise your blood calcium levels. Then when you have a condition which is called increased calcium levels in your blood or hypercalcemia, now we secrete a hormone that's called calcitonin, and calcitonin actually comes from the thyroid gland, from these cells that are called C cells. And what it does is it targets osteoblasts to absorb, so that it reabsorbs calcium from the actual blood and then brings it back in to the bone. And so these are going to be your bone building cells, your osteoblasts, and it helps absorb calcium from the blood back into the actual bone. So the osteoclasts and osteoblasts obviously do opposite things. PTH and calcitonin do opposite things. So when something does an opposite thing, it's called an antagonist, right? It's opposite. Vitamin D is also very important in terms of helping reabsorb calcium back into our bones. And then when calcitonin and vitamin D are active, they actually inhibit PTH. If PTH is active and increased in the blood, then it actually inhibits calcitonin and vitamin D. Then anytime there's kind of overload stress, so whether it's gravity, whether it's tension on a bone through weight training, whether it's resistance type activity, that is when you're going to have increased stimulation of those osteoblasts. And then what's going to happen is that you're basically telling your body, hey, I need more calcium. So more calcium will actually get reabsorbed into the bone from the blood. Then just little diagrams of what these cells look like. So these are the osteogenic cells that will then become osteoblasts. They look like little bricks, kind of remind me of Legos. And then a mature osteocyte looks like this, and then it has the little canals that then feed in to the actual canaliculi that will then provide the calcium that goes in. Then we have different stem cells that actually become these actual osteoclasts. And what you see here, these are called resorption bays, and what they're doing is they actually embed into the endosteum of the bone and then within the little trabeculae, and then they will actually secrete from these lysosomes. Hydrochloric acid will actually go in to these bays and actually start dissolving the bone itself. Then abnormal bone growth is called ectopic ossification. So ectopic means outside of the normal space. And so this would be abnormal. And so what you're seeing here, here's an example of what you would see in a heel where somebody has an actual bone spur. You can have bone spurs in your ankles. You can have bone spurs in your elbow, behind the patella, in the shoulder, any place that there's actual friction that occurs where you will kind of basically be stimulating these osteoblasts. And so you don't want this ectopic ossification because obviously bone spurs are not something that is normal. And they can be very painful. In some cases, they actually have to be dissolved or shaved down by a podiatrist or orthodoc. And then over here, what you're looking at, this is the aortic valve in the heart, and it's become very sclerotic. So when you have what's called arteriosclerosis, all right, this is actual calcification that occurs within the valve, and then this is also the type of calcification that occurs within arteries when there is plaque buildup. And the process of that inflammation and calcification in an artery is actually called arteriosclerosis, and then also arteriosclerosis once it becomes this hard. And obviously this is going to be a valve that is no longer functioning properly and has to get replaced. So what this does is it causes stiffening of the tissue, and it hardens the valve, and it makes it very difficult for the blood to pump through when the ventricles contract in the heart. When it happens within an artery itself, obviously it narrows the space, and then it can also increase the risk of some of this plaque getting loose and then actually traveling and becoming an embolus, so it would be a plaque embolus, that travels through a vessel, and that could cause an issue in the brain, causing a stroke, or it can actually occlude an artery within the heart itself. Then calcium deficiencies, these can occur in children and obviously in adults as well. When it happens in kids, this is called rickets, and so you see that the bone itself is very, very bendy and very pliable, so it's very soft. And so as the child grows, it causes problems because now you don't have the density in the bone to withstand the weight of the individual as they're growing. So the bones themselves are very thin, so you can kind of see some spacing here that is not supposed to be there. And so the bones are more likely to have issues with fractures, and then obviously deformation as that bone grows. In adults, when you have an osteoporosis, what this is now you have actual thinning of what you see in the actual vertebrae themselves. So this is an example of what can happen when it becomes very severe. And then what you see here are the actual openings or cracking within the trabeculae. Over here on the left is normal, here on the right is abnormal. And so then your scaffolding for this gets very, very thin and very weak, and then you can actually have compression fractures that occur here and then thinning. And then you'll see here on the outer portion here, we did have some more of that compact bone, then it's not able to withstand the stress, and then that is also why a lot of individuals that have this issue actually then start getting shorter, or you'll see some of that curving that starts to occur in the actual spine. Then in terms of bone fractures, fractures are obviously damage to the bone. They are breaks. What is called a closed fracture, this is where the bone itself has not penetrated the skin. Open fractures, what we call compound, these are actually bones that have now broken through the skin. And you can go on YouTube and see some pretty gnarly actual open fractures that occur as they're occurring. Stress fractures, these tend to happen from overuse injuries. So a lot of, for example, ballet dancers can get these in their feet. Gymnasts will get these in their legs and in their spine. Runners can get them. Individuals that do a lot of throwing or tennis type sports, racket type sports, they can get stress fractures in their elbows, and they're just repetitive type use injuries. And they're kind of like these linear cracks that occur, and they can become very, very painful over time. And the only way to really heal these is to stop doing the activity and let the bone heal. So pathological fractures, these would be primarily caused by disease, so a cancer or osteoporosis, rickets, those kind of things. And then in terms of treatment, so closed reduction would involve, just casting in place, setting the bone, and then open reduction, these are going to be the ones that actually involve surgery, and this is where you have, obviously, the orthopedic surgeons have some fun and go in and do their carpentry. And so orthodox are actually basically glorified carpenters, and they're amazing in the skill that they're working with. And then healing time for any kind of fractures can be on average 6 to 8 weeks. The younger you are, the better you're going to heal, and the faster you're going to heal. So when you look at your types of bone fractures that occur, transverse is just going to go across, maybe just a cross-section of the actual plane of the long bone. Linear fractures just go, obviously a little line in the bone itself. This is what a lot of stress fractures look like. And then you can have a non-displaced fracture or oblique fracture where it can go at a diagonal angle. This would be a displaced compound type fracture, open fracture, where you actually see the spiraling that can occur. Spiral fractures can do this and then even end up looking like this. So this is actually going through the skin of the individual. So these are obviously very, very severe. And then spiral fractures has been an actual where the one side of the bone itself was fixed and then the other piece of the limb rotated around it and just snapped it in a rotational manner. And these can occur in the humerus, it can occur in any of the long bones themselves. And usually spiral fractures and these displaced fractures will require surgery. Green stick fractures, why they're called green stick, is that they tend to happen more on the outer edges of the bone, usually the lateral edge. And kids are actually more susceptible to these because their bones are actually a little bit softer and a little more bendy. But it's called green stick. And for these, they usually just end up, placing or just immobilizing the limb itself for a little while. And then comminuted fractures, these are more compressive type fractures where you actually have bone itself that kind of blew out. And these are, in some cases, going to require surgery, obviously, to place a rod within the bone to connect the two ends, and then cleaning up some of the mess that has taken place from the bone that actually blew out. Then this is what I like to call my etch and sketch image, but this shows some of the fractures that it can actually occur within the spine. And so this is why it's so important, if you do suspect spinal injury, that you do take the time to do spinal immobilization on the patient, because you're actually impacting what could also be happening within the spinal cord itself. And so what you see here, this is a sagittal lateral view of the spine. And then in these little open spots, all right, those are called intervertebral foramen. And what that means is that they're little openings that get formed between vertebrae, and that is where the spinal nerves actually exit from. So the spinal nerves are connected to the spinal cord. So you can see in some of these diagrams that when you have any translocation here, for example, this anterior-posterior distraction injury that has taken place, you're going to have some issue going on with the actual spinal cord. All right. Here as well, that can also occur. So here you have actually parts of the body of the vertebrae that have actually broken. Then that can directly impact what's happening within the actual cord itself. And then in this spot here, this is a compression type injury. So anything where you have a person gets slammed down or pressure from top down or bottom up, and then you have the vertebrae itself actually fracture and crack. In some cases, these can also lead, obviously, to spinal cord injury. But the ones that are more likely going to need to lead to a type of paralysis, or if there's any kind of perforation of the cord from any of the bone, like for example down here with a burst fracture, then that could also lead to spinal cord injury. So this is why it's really important that you get good at doing these trauma assessments when you're checking out the spine. Then rotational injuries, these are going to be when there's an actual, fixed and then boom, usually a snap of some sort, some torque that took place on the spine itself. And then you can actually crack within the vertebrae, you can actually crack within the facets themselves. And then it can be more of an anterior torquing, or then it can actually go all the way through and then cause more displacement or shear injuries in the actual cord. So spinal fractures are a big deal. And again, real important to get good at doing these trauma assessments. Then skull fractures, obviously the big risk here is what's underneath is the brain. So if there are any kind of skull fractures, whether they're hairline depression fractures or a compound fracture that is actually exposing blood, brain tissue, these are going to be very, very serious because there is going to be inflammation and probably some bleeding that is taking place underneath. So when you're doing a trauma assessment, checking the skull, be thorough, but don't be rough or use a lot of force as you're actually going through and palpating the skull of the individual. Then facial fractures that can occur, these are called Lefort fractures, and they're classified in grade from 1 to 3. So the 1 is obviously going to be the one that only impacts the maxilla itself. And so as you're looking at here, this is the bottom portion of just below the nose, that's the maxilla. Then the Lefort 2, the second degree, is going to be going further up and then include part of that inferior orbit of the eye, and then up under with the cartilage, and then probably a little bit of the nasal bone. And then the Lefort grade 3, the reason why this one is so much more serious is, yes, you face planted or smashed the face into the windshield. Obviously from these you always have to suspect some kind of brain injury. There could be some issue going on also with an optic injury, and then also a cervical spine injury because of the force that can take place when you have a fracture on the anterior portion of the skull, which would be in the face. And then back here, this bone back here is called the sphenoid bone that makes up the posterior part of the orbit of the eye. And that is directly connected and portioned to where you're going to be having the temporal side of so right here, this is where the temporal lobe of the brain is. This is obviously all frontal lobe, and then that can then directly impact those portions of the brain. So Lefort injuries, also very critical. If you notice that, it's important obviously to note that as you're transporting the trauma, because obviously they need to be aware that there very likely could be a brain injury. Then all fractures are going to heal in this manner, so you do need to know these steps of healing. First, you have a hematoma formation, so you're always going to have increased blood flow going to the area. This is going to cause obviously the inflammation and the swelling that you see within a fracture, but the whole point of it is to get blood there and get the immune cells there to start the healing process and take care of any infection that may be taking place. Then we have what's called a soft callus formation, where you actually have some fibrocartilage that is being formed. You have a lot of fibroblasts that go to the area. You have chondroblasts that are within that region, so you have a lot of healing that is starting to take place. And then you have the hard callus formation. And then the last thing that'll take place, it'll take about, anywhere between 3 to 4, sometimes 6 months to occur, is what is called bone remodeling. And during the bone remodeling phase, the osteoclasts are actually very, very active in cleaning things up and smoothing it out and basically being the sandpaper of the bone itself to heal back within these soft callus, and then within the hard callus formation, you're going to have a lot more activity from the chondrocytes, obviously, but then also from the osteoblasts. Then in terms of looking at the bones themselves, I do want to go through some of the names and partially what you're going to see within the skull, and then regions of the actual limbs themselves. So this is a zoomed in view of what you have with the facial bones and then also the frontal bone of the skull. So again, you'll see these little words for, like the foramen, for example, are just little openings. A notch is a little open foramen, basically a little cutout. This back here is fissure. Then you'll see more foramens underneath. These are for the facial nerve to pass on through. And then you'll see these regions where you actually have fusion between the bones. And these types of fusion between the bones are actual joints. And what they do is they form what we call suture joints. And in the skull itself, the regions that form these types of joints or these sutures actually have a name. So the coronal suture here, this is what forms between the frontal bone and the parietal bones. Then above, in between the two parietal bones, there is a suture up here that's not pictured that is called the sagittal suture. That basically is where that mid-sagittal plane would slice through if you were to cut your head in half. Then on the back side, the suture between the parietal bone and the occipital bone, this is called the lambdoid suture. And then the suture between the temporal bone and the parietal bone, this one right here, this is called the squamous suture. And then this right here is the actual temporal bone. And then this feeds in directly into the zygomatic bone, which makes up your cheekbones, that is then fused to the maxilla. And then the maxilla is fused to the nasal bones, which make up the part of the nose. Then you have your mandible, which is inferior, obviously, and then that articulates here in this region that is the condyle, where the temporomandibular joint actually forms between the mandible and the actual temporal bone. Then this opening right here, this is called the external acoustic meatus. Just to point that out, this is where the sound waves enter into the external portion of the ear canal, and then that will hit a membrane, your tympanic membrane, that then vibrates, hits the little teeny tiny bones inside the ear, and then will feed into an opening within the inner portion of the skull that contains the nerves that will help you hear and then also maintain your equilibrium. Then inferiorly, what I wanted to point out here, this right here is the opening that's called the foramen magnum, and it's the biggest hole that we have in any of our bones, other than the obturator foramen that's in our hip. And why this matters is that this is where the actual spinal cord connects to the brainstem. It's kind of a seamless connection that takes place. But when you have a brain herniation, where you actually have part of the brainstem pushing through because of intracranial pressure, this is the opening that it's pushing through. Then lateral to the foramen magnum, what you have are these little condyles. These are called the occipital condyles. And these little guys, what they do is they actually articulate and connect to the first cervical vertebrae. And then below that is going to be the second cervical vertebrae. And so those two vertebrae obviously are very critical because they are very closely located to that portion where you have that articulation with the occipital bone. And any kind of cervical injury that is going to be up in like C3, C2, C1 area very likely is going to cause enough inflammation where it's actually going to impact what happens in that articulation, that region where you bring together the spinal cord with the brainstem. And the bottom portion of the brainstem, that's called the medulla oblongata, that is where your respiratory center, your cardiac center, and what's called your vasomotor that controls your blood pressure is located. So this is why individuals that have very high cervical injuries, especially any kind of transections through those cords, actually in some cases die because they stop breathing, their blood pressure tanks, and their heart stops, but also because of how it can directly impact your ability to breathe. And so those are very, very serious injuries. All right, then with babies, obviously babies are not going to have full-blown sutures that we have as adults because the bones haven't fused together because we have little baby brains. And the little baby brains are growing underneath, obviously, the skull bones of the baby. And you're going to have areas that are going to be softer. And these are regions that just have fibrous membranes. And then underneath that, obviously, is going to be the brain. And so what happens is that within the coronal suture, this superior portion, you have what's called the fontanelles. So you have an anterior fontanelle, and then you're going to have a posterior fontanelle. And then you have that region of the sagittal suture that is all fibrous. Here is going to be your coronal suture. Here's the sagittal suture, and then here is going to be the lambdoid suture, and then you do have some lateral fontanelles. This one's called the sphenoid suture, because this bone here that is just on the lateral portion is called the sphenoid. And so what's important about this is that these areas in a baby's skull are very soft. This anterior fontanelle is also a very important landmark when you're doing an assessment on a child that you suspect is hypovolemic or is, doesn't have enough fluid. This is also an area where if you have any kind of swelling that is taking place and it's distended, then that could be indicative of a hydrocephalus issue that's going on where you actually have more fluid that's building up. So it should never be too distended or too sunken, because if it's too sunken, that's usually a sign of dehydration in a child, or it could also be a sign that there's a serious issue obviously going on with something with the fluid within the brain. So that's what these fontanelles are, and these are found within that infant skull once baby is born. Then in terms of curvatures, so when you have a baby, so there's a little newborn, obviously they're not going to have a defined curvature in the spine and the cervical region or down here in the lumbar region. So this little kind of C-shaped curvature is just called the primary curvature, and I always think it's just so cute. But babies start to develop these curvatures up here in the cervical region and the lumbar as they start increasing the strength of the muscles that will then hold up the head, and then obviously as they start getting ready to walk and they're able to move the lower limbs and the upper limbs. So our vertebrae, we have 31 vertebrae, and so what you have here, these first two, the first one's C1, cervical vertebrae is known as the atlas, and then the second one is known as the axis. And what's unique about these two is that the atlas itself, this is what articulates from these two little surfaces to the actual occipital bone. And then just below that, this is the axis, which is the one right below, and then anteriorly you have this little nub that articulates to that atlas, the first cervical vertebrae, and then it's this vertebrae here that rotates left and right that allows you to rotate on this little bump that is called the dens, and that's why you can shake your head left and right. Then we have 7 cervical vertebrae, we have 12 thoracic, 5 lumbar, and we have 5 fused sacral, and then 4 coccygeal vertebrae. And so the easy way to remember these are that you're going to have breakfast at 7, lunch at 12, then you have dinner at 5, then you have 5 snacks, and 4 cookies or 4 cocktails. I assume all of you are over the age of 21, so if you like to drink, there's your 4 cocktails for your coccyx. If you don't, then you can have 4 cookies. But you can see that all these vertebrae are articulated, and each one themselves is an individual bone. So what happens is that laterally in between these spaces, this is where the spinal nerves will exit. Anteriorly, you see where the intervertebral discs are located, so this is where the body of the vertebrae are. And then on the sacrum, on the inside here, you'll see that there are openings, and these are really important because this is where the sacral nerves will actually pass through. And some of those sacral nerves that are really critical actually go in and innervate urinary organs, reproductive organs. So we kind of need those for reproduction, and then obviously to regulate any kind of urinary incontinence, and then obviously fecal incontinence that can take place. And then the curvatures, you have the cervical curvature, which is going to be more concave, and then convex is going to be the thoracic curvature, and then you have the lumbar curvature that then feeds in to the pelvic curvature. When you have abnormal curvatures, and I want to make sure that you guys know these, so a lateral abnormality is called scoliosis. An abnormality that is going to be either more convex, that's going anterior to posterior, so here we go anterior toward posterior, and it's going to be along that sagittal plane. So this is called kyphosis. You could also get kyphosis here, depending on what's going on. And then you have lordosis, which is going to be more of an inner curve that is occurring that is actually causing it to be more pronounced. And so lordosis obviously occurs with a lot of women when they're pregnant, but you'll also see this a lot with some athletes, for example, with gymnasts that will have a lot of curvature that occurs down here. And anytime there's curvature here, as you can see posteriorly, what it does is it'll bring more together those spinous processes, and then over time you can actually have more arthritis that starts to develop along the facet joints that where the two vertebrae connect on the lateral portion. So scoliosis, lateral abnormality. Kyphosis would be more of a thoracic early cervical abnormality in the upper portion, and then you have lordosis, which is going to be more inferior down within the lumbar to the sacral regions. Then on the vertebrae themselves, all vertebrae are going to have common landmarks. So you have the spinous process, that is the piece that sticks out towards the back. So when you're palpating the spine, you're actually feeling for that spinous process. You cannot feel the lateral, these transverse processes, because they actually have more muscle and tissue covering them up. Then we have spinous, the articulating facets are going to be these. So these are superior and inferior articulating processes that then contain the facet. The facet is the region that has the cartilage, the hyaline cartilage, that then articulates to the joint that is above and below. So this is the posterior portion of the actual vertebrae. And then the anterior portion is going to be this piece that has the body. The spinal cord passes through the opening that is made by the vertebral canals as you put all the vertebrae, stack them up like little Legos. Then in between, on the body itself, is where you have the fibrocartilage disc. And then the inner portion of that disc is going to be what's called the nucleus pulposus. And then this outer portion, this is that part that is made of fibrocartilage. Then when you have a herniation, what happens is that there is a tear now in that fibrocartilage, and now you have part of that nucleus pulposus herniating out through the crack and then putting pressure on that spinal nerve that is directly attached to the actual spinal cord. And so that can cause a lot of pain in an individual. And unfortunately, in the line of work that y'all are in, likelihood of having a cervical or a lumbar herniation is very good. So this is why it's so important to always make sure that you have some flexibility there, obviously, but also that you're strengthening around the core. And if you do sustain one of these injuries, it is really important to take that time to have the healing take place, because it can take anywhere from 3.5 weeks or longer. And then what's also going to occur is that the muscles that are around the region where this herniation took place is that they're going to spasm, and that can be very, very painful as well. Then your vertebrae types, I do want you to know the unique structures of each vertebrae. So what you're seeing here, you have first the cervical vertebrae. And so the 7 cervical vertebrae, what's unique about them is that you have these little openings in the transverse processes. And these transverse foramen, why they matter, is that they actually have within the vertebral artery, vertebral vein, and then you're also going to have some more of the actual, you'll have the blood supply that passes through here, and then you'll have the nerves that are going to be exiting in between the foramen that pass through here. So obviously there's a lot going on in these regions. So when I go back to my spine, and when you see this, all right, running up laterally within those foramen, that blood is going to go in and it actually supplies the brainstem, and also will go up and over and into the frontal lobe. So that is why it is so important that if you suspect a cervical injury, please take that time to do that spinal immobilization correctly. Then the thoracic vertebrae, what's unique about these is that they're going to have these little guys here. So these are going to be the articulating facets for the ribs. And then they also obviously have the superior and inferior articulating facets for the vertebrae above and below. So here is the facets, and then here's your superior facet, and then this is an inferior facet. And then down here, this is inferior articulating facet for the actual lumbar vertebrae. So again, these facets are going to form little joints with the vertebrae above and below. And then we also have obviously the joint here that forms when you have the disc in between, and then it forms it with the one just above. Then we have our sacrum, and again, our sacrum is 5 fused vertebrae, and then we have the tailbone that's attached to that, so you'll have 4 coccygeal vertebrae, and then L5 from the actual lumbar portion articulates here to S1, real common region where you can have a herniation, very, very painful. Well, then just to point out here real quick, so when you run on the elderly and they've actually had a fall, right, one of the real common areas for a fracture in the elderly are here on the sacrum, on the region that's called the ala, right? So this is kind of like the wing, lateral wing of the sacrum. Here's the one that's on the right, so right and left. These regions are real common spots for those falls, because when they fall, if they fall sideways, one, yes, they can actually dislocate the hip or they can fracture the hip, but it's also a likelihood that you can actually have a fracture here in the alar region of the sacrum. So just kind of keep that in mind and be real good about palpating that area and asking that patient, hopefully if they're conscious, if they have any discomfort there. Then within our ribs, on the anterior portion again, you're going to have the sternum. The whole sternum itself is actually 3 subset of bones. So you have the manubrium, then you have the body of the sternum, and you have the xiphoid process. Then you have the clavicle that is going to articulate to the sternum on the region that's called the clavicular notch. And then this piece of the clavicle is the sternal notch. This portion of the clavicle is called the acromial notch because it connects to the acromion process of the scapula. Then the ribs themselves are going to originate. The proximal end is on the posterior part of that thoracic vertebra, and they're named according to the rib that they articulate with. So here's thoracic vertebra number 1. This is your rib C1 that articulates directly to the manubrium. Then we have C2. So your rib number 2, articulates posteriorly, originates on T2, and then articulates anteriorly to the sternum at the manubrium and also the body of the sternum. And then this is that landmark that you want to find where you're going to have that C2, and then you have the region here is that second intercostal space between the second rib and the third rib. And working your way down through the sternum, obviously the body of the sternum, this is where we do our compressions for CPR. And then down here is going to be the xiphoid process, which is one of the landmarks if you want to find that on the bottom as you work your way through with doing CPR. Real common place where you don't want to hit that. And then our scapula obviously are posteriorly. And then our ribs, our true ribs are 1 through 7, which articulate directly to the sternum. 8, 9, and 10 are considered to be the false ribs. And then 11 and 12 are your floating ribs because they don't have any anterior articulation. Then the clavicle, again, is a nice little bone that articulates to the sternum on the medial end. So here's your sternal end. And then you've got the acromial end that connects to the acromion process of the scapula. This is that midclavicular line that you're going to find when you're palpating for that portion where you're going to do your decompression on the ribs or in the intercostal spaces. Then the ribs themselves, the head portion where the neck is, that is where they articulate to the actual thoracic cavity. And then the distal portion is going to be when they connect to the actual sternum. And then our vertebrae, again, you're going to have your disc. This is a symphysis joint. And you'll see that the ribs themselves actually share where they articulate to the actual ribs on the facets between those two within the T5 and T6, for example. And then you'll also have down here inferiorly, this is where it would then articulate rib number 7 to then the articulation with T7. Then the scapula itself, what you're looking at here is going to be, you have the inner portion, this is going to be the anterior surface, what we call the subscapular fossa. And then you have the posterior portion, which is where the spine is, and then the infraspinous fossa. So when we go through and we talk about the muscles, the scapula are actually the origin for the rotator cuff muscles, and then the rotator cuff itself actually inserts right here on that greater tubercle of the humerus. So the shoulder is actually made up of the clavicle, and then the scapula, and then the humerus. So that's that joint right there that forms the shoulder joint. Then our humerus, of course, the big landmarks on the proximal end, you've got that greater tubercle. Here's that intertubercular sulcus, and then the smaller tubercle, which is called the lesser tubercle here. So when you do your drilling for that IO, you're going to be going into that greater tubercle. And then the shaft itself, this is the long portion. And then here anteriorly on the distal end, this is where you're going to have the radius and the ulna articulate. And that radius goes here, ulna is going to go here. Then the radius and the ulna, these are the bones that are in the forearm. So medially, this is going to be where the ulna itself connects to the humerus, and then the radius is going to then connect up here to the humerus as well. So that forms a hinge joint. But then here between the radius and the ulna, you actually have what's called a pivot joint, where your radius actually pivots over the ulna, and then these guys can pronate and obviously cross over. And then on the distal end, you're going to have the radial and ulnar distal portions that then connect to the carpal bones of the actual wrist. And then in between, we have a fibrous joint that's called the syndesmosis, and it's formed by this interosseous membrane, which is really important because it kind of helps keep that joint together that is formed between the two bones and the larger spaces in between. Then the carpal bones, and I don't know why these came out blurry, but they did. These are the carpal bones, and you've got two rows, a proximal row and then what's called a distal row. So your radius actually articulates right here on what's called the scaphoid and the lunate. And then over on this side, you'll have the articulation of the ulna. And you have what's called the triquetrum. And then right above that is the pisiform, which is the bone that sits on top. So real common spots where a lot of kids will actually fracture the wrist, or when individuals fall and they brace themselves by putting out their hand. That is why the scaphoid right here and the lunate are two real common regions where you actually have breaks that take place. If you go further down, then this guy here, this is called the triquetrum, and this is where you form the articulation with the first metacarpal, which is then going to form that portion in the palm that then connects to the thumb. And then this is the first knuckle right here. So this is the metacarpal, first metacarpal, that then connects to the actual proximal phalanx, which is the first bone of the thumb, and then you've got the distal phalanx. Then in the fingers themselves, you have the other metacarpals. So the way that the metacarpals are numbered are 1, 2, 3, 4, 5, and then the digits are when the fingers have the muscle, bone, and tendon on top of them. When it's just the bone itself, those are the phalanges. And so all your knuckles that are from your palm to your fingers, that's these guys right here. And so those actually form a condyloid joint. I'll be talking about that later. And they articulate to the proximal phalanges of each of the fingers. And then you'll have a middle phalanx in the fingers that are not the thumb. That's why we have, basically 3 knuckles in our fingers. So you've got the proximal one that is going to form between the metacarpal and the proximal phalanx. And then the second one between the proximal phalanx and the middle. And then from the middle to the distal. So those are the bones that you actually have in your hands. Then our pelvis, this is obviously the articulation where the femur is going to connect to form the hip joint here. Here is your sacrum, and then this is the pelvis. And the pelvis itself is going to have a region that's called the pelvis inlet, and then at the bottom is going to be the pelvic outlet. The pelvic inlet is important, and what you're looking at here, this is actually a female pelvis because of the joint that is formed between the two bones. These are the pubic bones anteriorly. And this joint in the female is going to be broader, more like 120 degrees because of baby having to pass through. And then the joint formed between the two pubic bones anteriorly, joined by a disc. It's called a symphysis joint because there's a disc in between. So here is the male pelvis. So you see here where the angle is going to be more 90 degrees. And then here is that female pelvis where the angle is going to be greater. Then the os coxae is the fusion of 3 bones. So here you have the ilium, the ischium, which is what you're sitting on, and then this is the pubis, which is the anterior bone. And then this big opening is called the obturator foramen. This is where you have vessels, nerves passing through. And then this section here is called the acetabulum. This is where the head of the femur actually articulates into the pelvic bone, and then in here there's a little ligament that it connects to with the actual femur and the head, and it also helps maintain the articulation more solidly. So when you have an actual dislocation of the hip, a subluxation, it's a pretty bad fall that they took or some weird twist that they did, because this is a really good joint in terms of how it's been designed. The humerus into the scapula is not as good. Dislocations are actually more common up in that area. All right, then this is the medial portion for the actual os coxae that you see, and this is the inner portion of the ilium. And then right here, this is just called the greater sciatic notch. This one down here is the lesser sciatic notch. And why that matters is because it's called this greater sciatic because the sciatic nerve actually passes through here on its way down to the leg. Then the femur, here is the head that articulates into that region, and the fovea capitis is where that tendon is. So this goes into the acetabulum. Here's the head, the neck of the femur that is just beneath where the head is, and then you're going to have the trochanters, which are the points where you have attachment for many of the muscles that go into the femur itself. Then posteriorly, or actually anteriorly, this is where you can have the patellar surface where the patella connects, and then on the back side of the actual femur, you have this region that is kind of an opening. And this is where you have the popliteal artery, popliteal vein, and popliteal nerve that are going to be passing through that feed directly into the calf. And so this is a region where if there is a stabbing, you're going to have some significant bleeding that is going to take place. And you can obviously die from that because of the amount of blood that passes through there. So real sensitive spot on the back of the leg. Then the tibia and the fibula. So the tibia is going to be medial, fibula is going to be lateral. And what you have up here, this is where it articulates to the actual femur. So this is your tibial plateau. And then just inferior to that is going to be where the tibial tuberosity is located, and this is again that spot where you're going to find on the IO to palpate, and then drop down 1 to 2 fingers, and then you will be drilling into this space that is here medially where the marrow is located. And then up here at the spot, this is where you have the meniscus that actually will be located. That is also one of the cartilages that forms from fibrocartilage. And then the ACL and PCL of the knee actually will be here. So this is where you connect in on the inside of the knee to the femur, and then laterally you'll have from the femur on the epicondyles to the lateral condyles here of the tibia. That is where the lateral ligament and the medial ligament are going to connect. So your lateral collateral is here, medial collateral is going to be here. And that is when you have these twisting or lateral impacts for trauma that you can actually tear those ligaments. Then this again is a syndesmosis in terms of the joint. You have a fibrous membrane that separates the two bones, except that in this case you're not going to have the fibula rotating over the actual tibia, which would be pretty bad if that happened. Then distally, the medial malleolus, again, one of the points of palpation that you're going to have for when you do the IO distally, and then you're going to find that medial malleolus go up about 1 to 2 centimeters, and then that is where you're going to drill. On the femur again, anteriorly, you would palpate, find that patella, go back 2 centimeters, and then drill here for the IO. Then inferiorly, right here is where the actual ankle is going to connect, and so the talus of the tarsal bones actually forms here and articulates directly with the tibia. So the true ankle joint is actually an articulation with the tibia and the talus, and the talus itself is going to form a hinge joint. So the talus is this, so this is where the tibia articulates, and then why you're able to supinate and pronate your foot is because of the joint that forms between the calcaneus and the talus. This right here is actually a joint that goes sideways. So you're able to go inner and then outer. So you can supinate and then you can pronate when you turn your foot, tip it inward. So these are all your tarsal bones. So these are going to have gliding joints in between. And then these are your metatarsals, and of course the phalanges as well. And in your big toe again, you have a proximal and distal phalanx, and then the other toes you're going to have 3 phalanges, the proximal, middle, and distal, and then the metatarsals. And they're numbered the same. Big toe is going to be 1, and then 2, 3, 4, and 5. And then obviously when you have the tendons, the muscle, and all that attached to your toes, now we call them the digits. So when you look at how the articulation of the joint is, so here is the tibia articulating, this is a lateral view, so here's your fibula, and then here's the tibia, and then here are all the tarsal bones, and then metatarsals, and then obviously the digits. You also have the arches that form in the foot, but these are for to obviously help with our gait in terms of how we walk, and then be able to absorb the impact when you're actually stepping. I'm not going to test you guys on the arches, but if you care to know, you have the transverse arch that goes across the anterior portion of the tarsals. Then on the lateral portion where the pinky is, the pinky toe, you've got the lateral arch, and then you're going to have that medial longitudinal arch that goes in. Then the joint articulations are obviously very important because these are your connections between bones, and how they're set up is based on their functional, how they move, and then structurally what it is that they look like. Now in terms of a fibrous joint, so I kind of showed you that a little bit already, but they're generally immovable. So what happens here is actual fusion that occurs between the fibers. If they're left open, like for example the syndesmosis between the ulna and the radius, or the tibia and the fibula, those are not going to fuse. But like between the actual skull bones, those will fuse. Cartilaginous joints, these are the cartilaginous would be the joint between the rib and the sternum, and then the symphysis joint, this is going to be obviously between two bones that are separated by a disc. So between the two pubic bones on the anterior portion of the pelvis, and then the intervertebral discs form a symphysis joint between the two bodies of a vertebrae on the anterior portion. And the key word about this is that they're amphiarthrosis, which means they're slightly movable. Then a synovial joint, these are what we call a diarthroses, which means that they are now freely movable. So here's your suture joint on this portion here of the between the skulls. So obviously here is going to be your parietal bones. Here's the sagittal suture, coronal suture with the frontal bone, and then this is the occipital bone, and there's the lambdoid suture. Then we have a gomphosis, which is the joint that forms between the teeth and the bone, and you have these denticulate ligaments that actually would allow the adherence of the actual tooth to the bone. And when you're actually getting a tooth pulled, if you've ever heard that kind of crunch and snap, what you're hearing is the snapping of these ligaments as the dentist is extracting the tooth itself. They have very, very little movement because you don't want your teeth obviously wiggling a lot, but they are able to be attached, and you'll see that teeth themselves are very vascular, and they're actually, a type of bone, but it's then covered by enamel. Then the syndesmosis, this is that fibrous joint that forms between the tibia and then the fibula, and then obviously up only between the radius. Then your cartilaginous, so here are the ones that form between the ribs and the sternum. They have slight movement, but as you guys know, ribs very easily broken when you're doing CPR. And then our symphysis joints, which are, here is the most common one, the pubic symphysis joint, and then the symphysis joints between the actual vertebrae on the anterior portion. Then our synovial joints, these are going to be diarthroidal, or what we call freely movable. And this unique structure with synovial joints is that they are actually inside a fibrous cavity. All right, so they're in a synovial cavity that has synovial fluid that gets secreted into the joint space. And so what happens is the fluid itself helps provide some kind of lubrication, kind of like oil, between the cartilage, the articulating cartilage, so that there won't be friction. But as friction develops because some kind of, gait abnormality, some kind of injury, anything that changes the actual complete structure of the bone itself would then start causing friction, and then the cartilage can rub off, and then obviously you could have bone to bone, and eventually you'll need a knee replacement or joint replacement of some sort, depending on where that is. Then we also have bursas. So these bursas are actually kind of like, think of them as little ball bearings that run along the regions where there's going to be a tendon passing through, and they actually allow easily more of that freedom of movement within the joint itself. And so in this case, you'll have some anterior bursas within the knee. We have bursas in our elbows. We have bursas in our shoulders. So any place that you're going to have this more freedom of movement, you're going to have that. Then this is looking down onto the tibial plateau. So this is the ligaments that are going to make up your ACL, PCL, and then you have your lateral ligaments within the knee joint itself. And so what you're looking at, superiorly looking on down, this is your ACL, this is your PCL back here. And so this right here, this is a meniscus. And so this is also made up of that cartilage, the fibrocartilage. Then in our hands, we'll have, some of the cartilage that's going to be between the actual carpal bones themselves. But then our tendons have an actual sheath that covers it up. And so that is for the protection of the actual tendon itself. And so sometimes when you get tendinitis, what happens is you actually have inflammation of the tendon within that sheath, and that is why that region actually ends up getting painful, because of the inflammation that is occurring. Now, the range of motion of an actual synovial joint has to do in how many planes of movement do you have. So uniaxial means you only have one plane of movement. So for example, your elbow, your knee, your ankle, when you point up at the ceiling or push down, point down your toes, that would be considered to be a uniaxial movement. Biaxial is going to be in two planes of motion. So for example, what you can do with your fingers, you can open them up and close them, and then you can also bend them forward and then bend them back. That is considered a biaxial joint. Same thing with your wrist. You can flex it and you can extend it, and then you can flex it laterally and medially. Multiaxial joints, these are going to be that move in the three planes. For example, your hip and your shoulder. They also call these hypermobile joints, where a lot of people will say sometimes that somebody is double jointed. It's not that you have two knees or two ankles. It just means they have a lot of elasticity in those ligaments. And in some cases, that makes you more prone for having sprains of those ligaments and then within the tendon of the muscle. An axis of rotation is just 90 degrees in relationship to the actual plane of movement. So in this case, this is the actual sagittal plane, and then the axis of rotation is going to be perpendicular to that. So this would actually move in the actual frontal or coronal plane. Then here we have the actual frontal axis, and so the axis itself runs along the frontal plane, and then the movement takes place along the sagittal axis or sagittal plane. And then here we have a transverse plane movement. So now you're going to actually do internal rotation or external rotation along the transverse plane, and then this one is going straight down within what would be the sagittal and frontal planes. So our most movable joint that we have is called a ball and socket joint. And so this is what you're going to have in the shoulder and then also in the hip. So then remember that in the hip, so here obviously we've actually opened it up and then moved the femur outerward, and it actually inserts here into that actual acetabulum. And so this ligament right here is the round ligament that goes from the little tip of the femoral head, the fovea capitis, and then into the actual hip. So it's very well attached. Then we have within the shoulder, now we have muscles that help hold it together in addition to ligaments. And then in here, this is the glenoid fossa of the scapula, and then here is the humeral head. And then laterally over here would be the larger greater tubercle, and immediately would be the lesser tubercle. So what this joint actually allows is a number of different motions. So what I want you guys to remember are just what the names of the motions are. And so I'm going to go to the pictures and actually describe them. So what you have here, anytime you have what we call flexion, all right, is when you're actually decreasing the angle between two bones. So if that arm was straight down and then you go up, you're decreasing the angle between the humerus and the scapula. So that causes a flexion. Here at the elbow, obviously, you would also have flexion that can take place. Extension is when you're now increasing the angle between two bones. So obviously here the arm is extended. So if this arm was flexed and then you went to extend it at the elbow, you're increasing the angle between the radius and the ulna and the humerus. So extension is increasing the angle between two bones. Hyperextension is when you're increasing the angle beyond the normal range of motion. If you went further up, all the way up here in the hand, or with the arm, you would have hyperflexion, where you've now hyperflexed or flexed that angle beyond its normal range of motion. This right here, this is called circumduction. And so what you're having is that you're moving it more in a cone shape. So you have one point of that arm, that limb is attached, and then the distal portion is going to be able to move in a larger rotational fashion. So this is called circumduction. Then internal rotation, you're now moving in the transverse plane. So now you're able to rotate internally and then rotate externally, as you see here. And so when you're doing an IO, when I talked about internal and external rotation, that's what you're doing up here at the level of the shoulder. So when the arm is extended and you want to do an IO on an individual, it's much easier. A lot of places will teach, do it, bend the elbow and then move the arm in. Well, it's much, much easier. You'll have more range of motion that happens to expose that greater tubercle on the lateral side of the humerus if you take this arm and then take that thumb, rotate it inward, and then line it up underneath, put that thumb to the butt. Easiest thing. There's a doctor taught me this. I did it in a cadaver lab. Very, very cool. So much easier to see. And maybe perhaps when you guys go to the cadaver lab, they can actually resect back the tissue here on the humerus, and you can actually see how it actually rotates better and you expose more of that greater tubercle on that proximal end. Then obviously here's hip flexion from the femur up with what's taking place with the os coxae. And then abduction and adduction. So we have our midline of our body. And abduction is moving away from the midline in a lateral fashion. And then with adduction, it's the opposite. Now you're moving toward the midline. With our hands, obviously, if we open up our fingers, that is also abduction because you have a little midline on your hand. And then when you bring them together, that would be adduction. We can also do abduction, obviously, here on our hip. And then when you bring the hip back together to the midline, that is going to be adduction. So that's your ball and socket joint. The pivot joint, this just means that it's able to rotate in one plane. So in this case, obviously, we can rotate it in the transverse plane. So this is where the occipital bone would articulate to the atlas, which is C1. And then this right here is the dens. And this is where the anterior portion of C2 articulates to C1. And then this is where you have this little transverse ligament that keeps these two guys together. And then you're able to rotate your head left and right. Then when you nod your head up and down, now that's a hinge joint here between the occipital bone and C1. But the pivot joint allows for rotation to happen. And then we also have the pivot that takes place here between the radius and the ulna. There's a ligament there. It's called the round ligament. And then that's what allows for you to pronate your hand over and then rotate at the elbow joint. So you see that there's no flexion taking place here between the radius and the humerus. It's taking place between the radius and the ulna. And they allow pronation and supination, or lateral rotation up in the head. All right, so here's your supination, hands open, and then pronation, rotate over, and that is taking place here. And then at our head, lateral rotation left and right. Then gliding joints, these are going to be joints that just glide along their long axis, so just a little bit of movement, but just enough so that you can actually move the joint itself. So this, you don't have a lot of movement here between, but the movement, the bigger movement that you have at the wrist is here between the articulation that happens between the radius and the ulna at the wrist level within the proximal row of the carpal bones. Then again, gliding joints between your tarsal bones, and then the other really important spot where you'll have gliding joints are going to be here between the superior articulating facet and the inferior facet that you'll have of the vertebrae above and below the bones. So really critical. Facet fractures can be very, very painful. They do happen among firefighters because of just, impact injuries, a lot of the stress and some of the pain that can take place from carrying a lot of load oftentimes. So, just keep that in mind. Back pain isn't always just a muscle. It could also be something that's actually going on in the bone itself. Then our synovial joints. So up here at the temporomandibular joint is a synovial joint that allows you for condyloid. So the condyloid itself is going to allow biaxial movement. And then here at the level of the knuckle, so between the carpal bone and the first and the proximal phalanx, those are going to be condyloid joints. And then here you see you've got the radius and the ulna articulating with the proximal row of the carpal bones. So here are your movements. So condyloid joint, so you can abduct and adduct your thumb. So open it up and then bring it back together. Here's your abduction, and then adduction obviously of the fingers. But then also we can have the flexion and then extension back up to the zero set, and then hyperextension when you hyperextend completely your hand towards the back. So these are all the different types of movement that can take place at the wrist, where you have the articulation between radius, ulna, and the carpal bones, and then within the fingers themselves. And then a cool thing that we have with our, I'll just finish the condyloids and then I'll get to the saddle joint. So your mandible, you can do these fun little movements, so making faces at people. Protraction is just the jutting out, so you're actually moving a bone forward on that anterior plane along the sagittal plane. And then retraction and lateral excursion, side to side, is going to take place along the transverse plane. And then elevating and depressing is when you open and close the mouth. Then at the feet, like I explained, the joint action takes place between the talus and the actual calcaneus, which is the heel bone. And so inversion, or what we call supination, and then there's eversion, or what we call pronation. And then our hinge joints, these are going to be between the knee and the elbow, also between the knuckles, and then between here, the tibia and the talus. And so what happens here is just flexion and extension. It's the only thing that can actually take place. And then what you're seeing here posteriorly, this is the PCL, anteriorly would be the ACL, and then you have the lateral collateral ligament, and then here's the MCL, the medial collateral. So hinge joint motions, flexion, extension. At the ankle, we have what's called dorsiflexion, because you're decreasing the angle here between the the talus and the tibia. And then plantar flexion is again going to be posteriorly between the talus and now the tibia as well. So you can have dorsi and plantar. And then we have our hip flexion, and obviously extension and hyperextension would be bringing your leg all the way back. And this is the cool thing I wanted to talk about. So the saddle joint actually forms between the tichetrum, which is on the distal row of your carpal bones, and the proximal first metacarpal. And so the proximal end here of the first metacarpal, this right here, this portion is called a saddle joint. And what it does and why it's important is that it allows us to do this motion that is called opposition. And opposition is really critical for humans because this is our ability to grip, to write, to properly hold an instrument and either do a fine movement or a gross type motor movement. And so it allows us to do this opposition, and this is something that's really obviously key in being a monkey as well. This is where we got it from. But on our feet, we actually don't have the level of dexterity that we have here with the thumb because of how the joint itself here forms between the first metacarpal and the proximal phalanx of the thumb. So, and then other joint movements, important for you to know regarding the scapula and the spine. So scapulas can actually elevate and depress. And then we also have protraction and retraction that occurs. So something to just kind of keep in mind when you're doing a lot of benching. You're going to have more protraction that actually happens with the scapula. And you can actually start to shorten the space here and the distance between the humerus and the scapula. And you can start having some problems with impingement and frozen shoulders. So that's why it's really important. Obviously balance doing, pressing type movements with pulling movements and engaging those posterior rhomboids and latissimus dorsi, in addition to what you do with the pectoralis major. Because one of the things that happens too, and when I get to muscle, is it starts to actually, when you do a lot of benching and not enough pulling, or a lot of hunching over, working on a computer, more anterior type movements, you're going to also shorten a muscle that is located here that's called the pectoralis minor. And when that happens, what it does is it actually starts pulling the scapula more forward and anteriorly, and then it causes more elevation, and then can actually cause more problems in terms of how everything then starts to work with the actual neck. So you got to be really, really careful with that. And if you already have that issue, I've had it, so I kind of know what that means, but then it in turn will start causing issues here laterally in terms of possibly impinging lateral movement and abduction with the humerus. So keep it balanced in terms of your workouts. Then the spine, obviously we can do slight rotation. They can take place in, below within the cervical vertebrae, and we can do lateral movements, lateral flexion and to the left or to the right, and then we can flex at the hip here. But this flexion that you're seeing is more between what is taking place with the femur and actually up here at the waist level. The actual flexion of what takes place between the vertebrae is very, very slight. So like when you do a crunch, you're having that flexion that takes place at the level of within the actual vertebrae. But when you do flexion this much, now you actually have muscles that are crossing the hip joint, and you're actually doing flexion between the hip and the pelvis. So it involves more what's taking place with the femur. All right, so that is the skeletal system. And again, be sure you take the quiz for this. That will be grouped with the integumentary and the muscle chapters. And if you have any questions on this, again, please reach out, and we will move on to chapter 6 and the muscular system.